Well, welcome. So excited for this seminar today. My name is Grant Wells. I'm Director of Innovation and Development for the Maternal and Child Health Research Institute. Today, joined by members of Bree's lab to discuss some outcome data related to preeclampsia and pregnancy. Um, Joined by Max and Dorian, two members of his lab. Just first of all, want to thank the MCHRI Education Committee. Um, we really can't do these seminars without them. So this is just a wonderful collaboration of folks who help us put these seminars on. Want to highlight the upcoming research community event that we're having at CAM on June 5th. This is a great time for anybody who's interested at all in connecting with the Children's Hospital and the folks and departments that are there, as well as researchers and teams who either enroll patients at the hospital or are interested in enrolling patients at the hospital. So please mark this on your calendar, sign up. It's going to be really fun. Hopefully the weather behaves. We hope that it'll have people that we can be on the lawn and just engage and collaborate. Special announcement here. MCHRI is scampering. If you don't know, the Children's Fund that is established by the Lucille Packard Foundation for Children's Health, that supports a lot of our efforts at MCHRI. We're able to facilitate some of our grants through that. So please make special note of this. It's a really fun time. It's a really great way to engage with your colleagues and do some fun things and kind of be outside. We'll have a table there and we'll probably have some MCHRI kids there as well. So mark that on your calendar. Just want to mention our upcoming physician scientist trainee to faculty career development seminar that we have on Tuesday, June 19th. Some of our really wonderful trainees who've received MCHRI clinical trainee grants. We've sponsored their master's tuition program that we also facilitate. And then they've also been a part of some other programs like the Department of Pediatrics Bridge to K and others. So these are some I think a really great seminar that is really top of mind for a lot of our trainees today. So if this is something of interest, please be on the lookout. Other items of discussion, our symposium agenda is set and final. So please take note of this. It'll be on healthy mothers for healthy babies, really interesting topics related to fetal therapy. We'll have a representative from the genetic disease screening program of the Department of California, and then a whole host of other really great folks. So please take note of that, put that on your calendar. Love to see you and kind of spend the day together. We are accepting abstracts. We've added a second poster session. So in years past, we've had one. We have been overwhelmed by the number of posters. We want to continuously be overwhelmed. So we've added another session. So we'll have two dedicated poster sessions for folks there. Please submit abstracts. We'd love to have them. Make special note here. We'll do our best to facilitate that on the boards that are in the event hall. So everybody gets kind of recognition. And then for those that don't remember or don't know, when you submit an abstract and you're a trainee, it gives consideration into our one of our session slots for an official speaking engagement. And we select the top five abstracts that we receive from that. So please encourage your trainees to present and submit their abstracts. We're really looking forward to that session. It's one of the highlights of the event as we get to see kind of the rising stars and rising scientist work that's happening in our labs. And then another really engaging part of our symposium is our Visionary Leadership Award. This is something where we recognize individuals' impact to maternal and child health research as well. And really this relates to the Stanford community. So if there's somebody that comes to mind, please nominate them We'd love to get kind of a broad array of impact. Some of the past award winners are on our website, so you can take a look at that as well. But today, we're going to be talking about systemic immune dysregulation induced by hypertension disorders of pregnancy persists after delivery. And this, I think, will be a really great discussion, something that we don't talk enough about. We tend to look at the initial outcomes of pregnancy, and so really interested by this discussion, and so thankful for people that have joined today. So I'll introduce Bree's team. So Dorian, you want to go first?
Yes, I will share my screen. Yes, so thank you everyone who is able to join the Zoom meeting today. So Max and I will present about systemic immune dysregulation in the context of preeclampsia. And we're very happy to share our work here during the MCHRI seminar, because I've been lucky to also have received funding from the MCHRI, a postdoctoral support grant, and also recently a pilot grant. And this study, one of the studies I will present today on this persistence of this preeclampsia signature after delivery is a study that is done here at Stanford and organized by Mark Haletsky and Virginia Wynn. So Max and I, we are part of the Gaudier lab, and in the Gaudier lab, we focus on various kinds of stressors that stress your immune system. For instance, we look at how your immune system behaves or changes with oral cancer, after surgery, in the case of endometriosis, but also in pregnancy. And for all these immune studies, we combine actually multiple omic modalities to really understand disease pathobiology. But also, what's really important for our lab, the goal is to bridge that gap between high-dimensional omic technologies and the biomarker discovery process. So can we really leverage these powerful methods into predictive modeling pipelines to be able to identify biomarkers to predict clinical outcomes, but also can you scale it to develop clinical assays? So these technologies, unfortunately, also come a little bit with challenges that can make it difficult to translate this high-dimensional omic data into actionable clinical applications. And one of the problems is this double-edged sword of dimensionality. So while we are increasing the P, so the amount of data that we gather per individual, the N, or the amount of individuals that we collect, is not changing very much. So it can be challenging to differentiate real signal that you want in your prediction model from noise in your data. And Max will present later during this talk about this algorithm, or explain this algorithm that we developed in the lab to deal with this problem of dimensionality. So, but this talk is about preeclampsia, and I don't have to explain to the members of the MCHRI that this is really still one of the great obstetrical syndromes. So 5 to 8% of all pregnancies will develop preeclampsia, and it's an important contributor to both maternal as well as neonatal morbidity and mortality. And one of the problems with preeclampsia is that it's currently in the clinic still only diagnosed when the symptoms are present. And then the quote-unquote treatment for preeclampsia is delivery. So what we really need is a better and earlier diagnosis of preeclampsia so that we can start better managing those that have a high risk of developing preeclampsia, but also then to prevent all those complications that come with developing the disease. So it's hypothesized actually that preeclampsia is a placental disease, specifically for the early onset preeclampsia, and that the immune system plays an important role in preeclampsia. So for instance, locally in your tissue, in the placenta, you have immune cells present that are very important to develop your placenta. So for instance, maternal NK cells and maternal macrophages, they will interact with fetal trophoblast cells to help them invade in the uterine lining and to open the maternal arteries. And if this interaction between those immune cells and the fetal trophoblast cells is not optimal, you will get a reduced spiral artery remodeling. You get placenta dysfunction, which leads to reduced blood flow and a stressed placenta. And this stressed placenta will start secreting proteins and vesicles in your circulation, which will then also lead to all that inflammation that you see during in the systemic circulation in preeclampsia. And this systemic inflammation and all this stressed placenta will lead to the hypertension, the proteins in the urine that you see. It will lead to liver damage, cerebral edema, etc. So the complications of preeclampsia are really for the fetus. You'll get fetal growth restriction, preterm birth, stillbirth, and in the mother, you will get organ damage. And if it's not treated, it can lead to death of the mother. And then also with preeclampsia, there's this component, which we will talk later about, is there is an increased risk of developing cardiovascular disease later in life. So you both have that local immunity that plays a role in preeclampsia development, but you also have that systemic dysregulation that you see. So the questions that we have in the lab is, how does that dysregulated local immune landscape, how does that look like in preeclampsia? That dysregulated maternal, both immunome and proteome, those dynamics, can you use them to predict preeclampsia development? But do you also have an immune memory of preeclampsia later in life that is somehow associated with a cardiovascular disease risk? So these are the three kind of objectives that we will talk today about in this seminar. Max will talk about the immune memory of preeclampsia, and I will go over the studies that we do for the local immune landscape and the immune dynamics. So to look at the local immune landscape, we analyzed a cohort of placentas that was collected at delivery. It was collected at Wayne State University by Dr. Nardi Gomez-Lopez, and we received 25 normotensive and 32 preeclamptic placentas. We particularly focused on the maternal-fetal interface by looking at the deciduum basalis, which with still some fetal tissue as well present in the regions that we investigated. So the placentas, they were formalin fixed and embedded. We make tissue slices of it, and then those tissue slices, we stain them with an antibody panel, a 40 marker antibody panel that goes into our mass cytometer. So you get like multiplex images of 40 markers. Those images we can spatially subset in decidua and villi, and those images we convert them into single cell data so that you can really look at frequency of cells, but also at the expression of functional markers. And in total, we collected of all these tissues and regions of interest, we collected about 400,000 cells, the majority in the deciduum basalis, around 320,000 cells, and then a smaller portion from the fetal villi, because we were really interested in the maternal sides of the placenta. So with this high-plex imaging, you can see here we identify on the left, it's labeled a couple of immune cell subsets that we can identify in the tissue. And on the right is a raw image where we can see the expression of DNA in blue, CD8 in green, and in red CD66B. So in this tissue section, with the red arrows, we can identify granulocytes, but we can also identify CD8 T cells, which are highlighted by the white arrows. So some of the data that comes out of this high-plex imaging is that we see, for instance, increased Cyclex-6 expression by trophoblast cells, both in the basal plates or the decidua and in the villi. And then if we look at granzyme B expression by granulocytes, we see the increased in the residua of preeclamptic pregnancies, while it looks the same in the villi of normotensive and preeclamptic pregnancies. So it looks like there is increased inflammation in the placenta of preeclamptic pregnancies. So this is preliminary data analysis. So what we have to do next with this imaging data is to build a classification model to really see what are the immune features and spatial features that differentiates normotensive from preeclampsia. And then for the dynamics part of this presentation, we have shown, or the lab has shown in 2014, that there is an immune clock of human pregnancy. So you can identify this immune clock that can predict gestational age. And building up on this work, Ina has also shown that this clock can be leveraged to predict the time to labor and potentially also to preterm labor. So we know that in pregnancy, your immune system changes over the course of pregnancy. So the next logical question would be, is this maternal immune clock dysregulated in preeclampsia? And when would you kind of see it, and can you use this dynamic to predict preeclampsia before the onset of symptoms? So for this kind of question, we again received samples from Wayne State University that were collected prospectively. So women, both whole blood as well as plasma, was collected at the start of like 12 weeks of gestation. It was collected every month until the third trimester, when they started collecting every 2 weeks. And in this cohort, there were 7 women that developed preeclampsia, which were then age matched with 14 normotensive controls. And in blood, we assessed the immune system by both measuring cell frequencies as well as phosphosignaling responses against LPS, interferon alpha, IL-2, or just in unstimulated cells. And then plasma was used to assess the proteome by using the SomaLogic platform. So in these data sets, or for each individual, we measured up to 2,000 immune features and about 1,500 protein features. So you really see it's a lot of data in one sample for one individual. And although this data set is also rather small, if you look at the number of individuals, you have a really high time resolution over the course of pregnancy. What we then did is to classify preeclampsia before symptom onset. We separated all our individuals and samples into different time intervals. So we have the first time interval represents early second trimester. So it's all the samples from week 12 to week 20. Then the second time interval, time point 1, is late second trimester, 20.1 weeks to 28 weeks. And then we have early third trimester and late third trimester, everything above 34 weeks. And then really the T0 and T1 are the samples that are collected before onset of symptoms. And then you also see that it's nicely, all the samples are nicely distributed over these time intervals. So with this time interval analysis, we can see in the immunome data, which is on the left, that the prediction or the classification of preeclampsia increases over the time intervals, with having time point 1 having a very good AUC of 0.74, which represents late second trimester. And then for the proteome data, time point 0, which represents early second trimester, you get an AUC of 0.7. So this might suggest that a combination of the T1 immunome with the T0 proteome might be a good strategy to classify preeclampsia before symptom onsets. And if we look at some of the features that come out of this classification model, For the immunome data, we see increased expression of CD44 by B cells and T cell subsets. So this points towards an antigen experienced and activated immunity. While if we look at the T0 proteome features, we see increased levels of leptin as well as cystatin C. So leptin is something that we already know from preeclampsia research that is increased in preeclamptic women. And then cystatin C is a marker that is used to assess renal dysfunction. So it already looks like at time point T0, which is early second trimester, that you can already see that there's real renal dysfunction in women who will develop preeclampsia. So this is the work that we do to look at local immunity and looking at maternal immune dynamics. So this is in a cohort that was collected at Wayne State University. And Max will now continue with the work or the samples that have been collected at Stanford as part of the EPOC study to really look at this immune memory of preeclampsia in later in life.
Sorry.
Turn up my volume.
Yeah, we swapped computers. So let me just quickly share my part of this presentation. Okay. Wonderful. Okay, thank you very much, Doreen, for this first half of the presentation. Now I will be presenting the second part, which is more specifically on the EPOC data set, what we've worked on, which is the effect of preeclampsia on cardiovascular health. So I'd like to begin by saying that I come from a different background than Doreen. I am actually a PhD candidate in the Institute for Computational and Mathematical Engineering. So mainly, I'm straightforwardly a mathematician. So my goal here will be to give some insight into what type of algorithms and mathematical tools we use to obtain these results that we use in the Gaudier lab. So I don't need to really remind you too much, hopefully, about preeclampsia, since Doreen just gave us a wonderful forward as to why it's a study of import. Again, it affects a decent chunk of all pregnancies. It is both affects the fetus and the mother, and furthermore, it increases the risk for cardiovascular disease later in life at about a twofold rate. It is also interacting with the immune system. As we've seen, we've got several studies that have indicated that preeclampsia is associated with dysregulated immunity during pregnancy, which is things such as reduced regulatory T cell tolerance against paternal and fetal antigens, and increased inflammation in circulating immune cells. But also, we also have reduced spiral artery remodeling, which is hypothesized to be mediated by dysregulated NK cells and macrophage immunity during placenta formation. So with this study, we had two main aims, which is, well, the third aim of that Doreen said, but here we divide it into two chunks. So our aim is using computational methods to first define a peripheral blood-based immune signature that is associated with preeclampsia. And on a more fundamental level, we want to know whether there is any immunological memory that persists of preeclampsia. To do so, we use the data that is derived from a broader project led by Virginia Wynn and Mark Klatke called EPOC, aiming to understand the effect of preeclampsia on cardiovascular health. So this data set is could be seen as actually three data sets. We've got an antepartum data set, which is blood samples taken from mostly women in their third trimester of pregnancy. We've got a postpartum data set that is taken from women 6 to 52 weeks after delivery. And then we've got finally a midlife data set, which is blood samples taken from women 5 to 20 years after delivery. And the data sets are relatively balanced between controls and preeclamptic cases. However, to quickly note, we do have actually some overlap. So we have some patients are present in more than one data set. We have about 50 patients between antepartum and postpartum that are present in both, where with 17 preeclamptic patients between both. However, there is no overlap at all between any of these two data sets and the midlife cohort. Hence, we were motivated to not look at a longitudinal approach, but rather a separate look at these data's the data as fully separate, and which allows us to incorporate everything. And if we only looked at this overlap, we'd be looking at only a very small subset of the data. So all these blood samples were collected, and then they were ran through our CyTOF pipeline. The samples were both run unstimulated and re-stimulated to reveal the type of immune response that is at work here. And effectively, each sample would then lead to about 35 different cell types that were investigated. And in each of these cell types, about 21 different signaling proteins were measured. So effectively leading us to about 2,000 features per sample collected. So as we see here, we have a much larger order of magnitude of measurements per sample than the total number of samples we have here in total. So like an order of magnitude. This will lead to a bit of a challenge as to how to correctly analyze and to correctly make discoveries based on this type of data that I will be addressing afterwards. Now, on this data set, a quick point on the demographics. We do have some significant differences between cases and controls as to BMI and blood pressure. However, so these are significant confounders that I just need to point out. However, nonetheless, I'll be talking about models that we've been able to build, and these models remain significant even when controlling for these confounders. So this is just a disclaimer. Okay, so the first point, how can we find an immune signature associated with preeclampsia? To do so, we built various sparse machine learning models. And the main model that we use is the one developed by the lab, the stable algorithm. Now, here I want to talk about how we kind of approach this objective. So the main hypothesis is here first of all, we've got a certain number of patients, but we've got a number of measurements that is much, much larger. And the underlying idea is that only a small subset of all the things we've measured is truly related to the outcome at hand, the current outcome. So effectively, in regard to here, specifically preeclampsia, but in other studies, it could be any other outcome, only a small subset of features are truly signal. The rest can be categorized as noise. To be able to directly discern this, many models have been created to be able to do this, called sparse models, which will effectively only select a small number of features in relation to the total number. You might have heard of a lasso or elastic net, adaptive lasso, stability selection. There are many, many different methods that exist out there to find specifically models that will work in this type of scenario. Nevertheless, all of these models have always a hyperparameter in the sense that it has essentially, you can see it as a dial that you have to tune so that the model will perform well. And effectively choosing the correct setting on the dial is not trivial and requires to do a lot of work. And so effectively, sure, you have this model, but then you have to do a lot of painstaking effort to find the best way your model works on your specific data set without at the same time overfitting. What Stable does to combat this is introduce a new idea wherein at the very beginning, before we do anything else, we create fake features. So we're actually making the problem worse in the sense that we're actually adding even more features than we had before. We're already complaining that we have too many measurements. Why are we doubling them? But this time we know that these features are fully noise. So effectively, using the data in a data-driven way, we inject noise into the data set. Effectively, each feature is used to create a duplicata of itself, but that is in such a way that it is fully unrelated to the outcome mathematically. So we know that this feature should never be selected, should never come up in the red features. It should always be selected as a gray feature, okay? And so we do this through two ways. Either we just randomly permute the feature, or we use Model X knockoffs, which is effectively a way of creating noise that conserves the same correlation pattern as in the original data set. And so once these features are created, we then do the following things. We start building models. You choose some other sparse machine learning model, such as Lasso, for instance. We choose the Lasso and we run it on multiple on bootstraps of the data. So effectively, what is a bootstrap of the data? We just randomly sample the data. So we can have duplicate patients showing up in it. But we're essentially this way, we're trying to explore what are the possibilities of the population at hand. So we're trying to artificially kind of boost, it's a classic statistical method to boost the exploration of the data set that we have. And for each of these bootstraps, we fit the model not only just once, but on multiple of the hyperparameters. So again, we take this dial that we have, for instance, for Lasso, we try multiple settings and we build it. So for each bootstrap, we build it once. Each time we build this model, it'll give us certain selected features. These selected features will then we'll write down, and over all of these bootstraps, for each one of these hyperparameters, we'll then get a frequency. Did feature A, it showed up only about 10 times out of 1,000. That's a feature selection, that's a frequency of 0.01. If it shows up all the time, that's a frequency of 1. So effectively, it gives us these trajectories here, wherein each feature will have a trajectory over the different hyperparameters and will be, so as we try the different dials, some features will be showing up more frequently than others. Effectively, what we do afterwards is we just take the maximum of each feature's individual frequency, selection frequency over all these hyperparameters, which gives us a ranking of all the features. This then gives us effectively some insight, because don't forget what we did at the very beginning is that we added these artificial features that we know are false. And so these will also be selected to a certain amount, but we don't want these to be actually selected. And therefore this term that we call the essentially estimation of the false discovery rate, FDP plus, serves this purpose, wherein it tries to choose a threshold wherein all the features above it, more to simplify it, all the features above it will be real features, and all the features below it will be a mix of real and artificial features. Therefore, we're able to get this threshold here. To kind of put it simply, we put this artificial noise in so we know how it behaves like. And then other features from the real data set that behave like the noise, we classify as noise, and those which are above the noise, we consider signal. So here, as you can see, we have the gold, which is the artificial, that we then classify the rest of this as gray, therefore noise, and those which are above, we put in red, we determine that's signal. And so this allows us to get a robust, small number of features from each model that can give us good predictions. Specifically here, on each one of these data sets, on the antepartum, we were able to build a stable model that got us AUC of 0.8. On postpartum, we have an area under the curve of 0.75, and at midlife at about 0.7. So this, as we can see, the prediction, the separation, how well the model can predict the separation between preeclampsia and healthy pregnancies is less strong as time goes on, but nonetheless, it is still the immune system is still being able to differentiate even 5 to 20 years later after pregnancy that between a preeclamptic pregnancy and a healthy pregnancy, which is a strong result. This led us to the next question, which is, however, how does this interact overall? Does the immune system remember preeclampsia? Unfortunately, these previous results, they didn't have the features that were selected in the end were disjoint, so there is no overlap. So this led us to look at instead a univariate analysis instead. So here what we did is we did Mann-Whitney U tests on each of the on all the features at each for each cohort, and kept the ones which were significant. Here we have Tasney embedding of each one of these features that were found significant. Now scaled by p-value. As you can see, most features are actually only significant at one specific time point, and a smaller subset are significant at multiple time points, with only 2 being significant at all over all 3 different time points for this analysis. We've got here, when we look at how these are grouping up, we've got at antepartum some T cell subsets over here. Postpartum, we've got some T cell subsets and adaptive immune cells groups. And at midlife, we've got here a group of adaptive immune cells as well, just to kind of see what's showing up together. More specifically, though, when we look at these features here, we see at the intersecting between midlife and postpartum, an overall decreased pCreb response towards LPS stimulation in innate immune cells. When we look at here, the intersection between antepartum and postpartum, we've got a difference in CXCR4 expression after IL-18 stimulation in innate and adaptive immune cells. And over here, at the intersection between antepartum and midlife, we have an overall increased basal p-STAT3 signal in CD4 T cell subsets. But however, when we look at more stringently at just the intersection of earlier time points with the midlife, so much further in life, our 2 features of interest are the green ones, and we've got here an increased B cell frequencies and decreased p-STAT3 response by CMCs after IL-246 simulation. So, and leading us to some very interesting results. So overall, we've been able to, throughout the study, find that preeclampsia has a detectable immune signature, even 5 to 20 years after delivery. That the signature evolves over time, yet it still is persistent to some extent. There are future steps to be still considered. It would be interesting to potentially look for the future, further phenotype the B cells that we saw just right before into subsets. And so yes, should we go to the thank you slide, Doreen? Yes. So again, big thank you to the entirety of the members of the Godier lab who have been central in collecting, processing, and analyzing all of this data. And as well to our many, many collaborators, specifically from me, a big shout out to Mark and Virginia, who have been very helpful in not only providing the data for this project, but also the analysis of this data.
Thank you so much, Max and Doreen. Just absolutely beautiful work and really highlighting the importance of a multidisciplinary team to achieve what you have. I'm Sushma Reddy. I didn't have a chance to introduce myself. I'm from pediatric cardiology, so I do have a special interest in what you're discussing, since many of these babies born to moms with hypertensive disorders, and many of these moms go on to have longstanding cardiovascular disease. And so, can we predict this early? Can we understand it better so you can intervene early and perhaps change the signature to a more favorable signature and decrease their long-term risks is particularly exciting. So congratulations to all of you. We'll open this up for questions. And while everyone is thinking, I had a few to get started. First and foremost, again, just outstanding, outstanding work. Are you able to tease out if your immune signature, which is so beautifully associated with preeclampsia, is there a way for you to tease out if there's a causative component?
Yeah, so I hope you can hear me. So I think it's really interesting to see, if we look at univariate analysis, the intersection between all three cohorts. It's two immune features, and one of them is B cell frequency. Unfortunately, in the panel that we measured, we don't have any B cell subsets. There are a few B cell subsets that are associated with cardiovascular disease. So I think it would be interesting to look into more detail of those B cell subsets. Causative, in our midlife cohorts, it's only 5 to 20 years. If we look at cardiovascular risk, it's only 5 to 20 years after last delivery. So most women, well, all women haven't developed cardiovascular disease like myocardial infarct or stroke. So I think it will be very important to keep following up, especially the ones that are in the antepartum and postpartum cohorts, to see who is going to develop cardiovascular disease, and maybe in 20, 30 years, we'll be able to get back to this data.
Mhm.
And then causative role for preeclampsia.
It's hard to really
Yeah.
say specifically,
Yeah.
Unfortunately, because to really be able to say whether or not this difference specifically later on in life, is it caused by preeclampsia or whether it's present even before, that would require, like, to be able to start addressing this question, we need to have like a data set that is taken not only longitudinally, but like at the very least before pregnancy even, to be able to see whether or not like we can can we tell before pregnancy even starts that there is like a significant risk of preeclampsia.
Has your team been able to validate your results in a prospective fashion? For example, could you take the beautiful predictive modeling that you've developed and apply it to the next 100 pregnancies that are seen at Lucille Packard? And are you able to, before preeclampsia occurs, is your signature able to predict, and then you follow them to see if your prediction, uh, how good your prediction is? Because
Yes.
I think that's what's going to help us translate your model to clinical use, and that would be so incredibly amazing.
Yeah, so I think that's something that we can definitely do to the models that Max has from the EPOC cohorts. Can we use are those training data sets, and can we then use those to validate and test it? For instance, in the Wayne State data that has data before onset of symptoms, or in any other data sets that maybe are publicly available. Because for proteome data, there's a lot more proteome data sets that have been published, which are not part here of this study. But yeah, it's definitely something that we should do to look at any data that's available before symptom onsets.
Yeah.
Can we use it to predict preeclampsia risk or preeclampsia developments?
Yeah, exactly. We would have to get another validation cohort. We'd have to have the same measurements, the same markers measured as we have here. But at the very least, what I can say here so far is that all these models are picked through cross-validation. Therefore, their prediction scores that I was able to give earlier are based on effectively looking at, you obscure a part of the data set, and the rest of the that is then used to test it. And you do this repeatedly, re-randomizing which part is obscured. So effectively trying to give us a good impression as to how it would work if we would be looking at a validation cohort. So effectively here it'd be, again, it would be, if the number here would be essentially about, this would be the performance on a, again, this is the estimation now, of course, a full validation cohort we don't have access to yet.
Thank you. Nick, one of you mentioned the use of immune clocks to predict preterm birth, some of Nima's earlier work. Is there any crosstalk between that immune clock and what you've identified in these patients?
Yeah, so we haven't shown it here, the immune trajectories that we have looked at in the longitudinal data. So you do see that those clocks for preeclampsia start to differentiate mid-second trimester. So you see some features starting, especially for features such as Cyclac-6 in plasma proteome, you see it start differentiating in the second trimester. So you do have this dynamic clock also in preeclamptic pregnancies. And then for the onset of labor, we predicted the time to onset of labor. So that's something we haven't done in this data set. That could be done as well to predict the time to preeclampsia, because that would also pinpoint a little bit more or help with management if you're getting closer to that, you know, okay, preeclampsia is going to happen in 4 weeks, you're going to see the symptoms, or in 8 weeks, you're going to see the symptoms. I think that would be valuable information for patient management.
Yeah, especially to bring those moms closer to a high-risk center. And then there are so many teams across campus, across the country that are generating this huge volumes of multi-omic data and trying to integrate the data. Do you see a future where the methods that you've applied could be made available to the greater community so that everyone else can also begin to predict events prior to clinical symptoms?
Yeah, so I think, or for instance, the stable algorithm that Max presented
is already publicly available.
The code is available on how to use it. And I think, especially at Stanford, we really try to, whenever we publish a study, all the data or the raw data gets published as well, so that people can both look at the code that has been used for analysis, but also really look at the data and use it themselves.
And the methodology is fully transparent, yes.
To reuse the data.
We'd be excited to see people use stable and our different approaches. It'd be awesome.
It's amazing. And if there are no other questions, I had one last comment. I don't see any other questions. So I just wanted to bring up for your consideration, IL-6 is emerging as an important risk factor for heart failure progression, both HFpEF and HFrEF in the adult world. And there've even been some pilot clinical trials looking at anti-IL-6 antibodies. So in case that comes up as an important factor in your cohort, of course, I don't know anything about treating during pregnancy, but those who have long-standing increases in IL-6, if their chance of heart failure is going to be much higher, maybe that's a group that could be considered into these clinical trials. So IL-6 for your consideration.
Thank you.
I don't see any other questions, but congratulations to both of you and your team. This is just superb work and very exciting. Grant, I'll hand it back to you.
Thanks, everybody. Yes, it was wonderful presentation and great questions. And this is just such an exciting seminar just to have today. Feel so fortunate for the lab to come out and just present this wonderful data. And yes, the whole purpose of these seminars is to establish some collaborations, get ideas flowing. So if things spark from this, that'd be wonderful. Feel free to ask me questions directly or get in contact with Dorian and Max. But thank you so much again, and we'll see you back in June. Thanks, everybody.
Thank you, everyone. Thank you again for the opportunity. This was terrific. Thank you.
Oh, it's our delight. Have a great day.